What's going on, podcasting world? Welcome back to another episode of the Core Consult RX podcast, episode 96.
96. Slowly but surely.
Cole's back with us today.
Yes.
So we unfortunately had to have him miss the last episode. I'm glad to have him back now.
I had to sit out on the marijuana podcast.
Yeah, he was skeptical what he was maybe doing, but no, we're just kidding. We told you, we told the viewers or listeners rather, you were out with family and stuff. So
right.
I didn't call you out on this one.
Was I or was I working? I don't know. That's all I do is work or with family.
Remember, I learned my lesson from, questioning your commitment to
my motives and my commitment to the podcast.
That's funny.
Yeah. People were sending me so much hate mail. I was getting death threats. Did you know that?
Everyone listening, that is super not true. 0 death threats have ever been issued.
Oh, dude. How long has it been since our coronavirus podcast? Was it it's beginning of February?
Probably something like that.
Can you believe what has happened since then?
Yeah. I've been telling people at my clinic and whatnot that if any of us get it, I feel like it's going to be me first because I talk so lightly about it on the podcast. Some would say maybe made fun of it.
We kind of did.
And I feel like, that's just going to be karma now, and I got to cash in on that.
Listen, posterity, or I should say the future will show that at that time, it wasn't that big of a deal.
Right.
Especially here. There were literally 11 cases when we recorded that podcast in America. So obviously things changed a little.
Yeah, whoops. Sorry about that.
Oh, man. They just, I was telling you, but Friday when they declared the national emergency, the pharmacy just blew up. And then today they announced that they were closing all the schools in South Carolina. So needless to say, I've just never seen lines that long at our store, maybe, other than hurricane season. It's pretty much the only thing. It's crazy.
That's rough. My wife said the same thing. It was just nuts. Yeah. And people are rushing in asking for flu shots and all that stuff.
Flu shots, pneumonia shots, just any shot.
Yeah.
They're like, is there anything I can get? I'm like, there's things you can get. Is it going to help you? No.
Ish. Maybe not.
You might not get the flu. Be great.
So I think we need to do a follow-up episode at some point. And so I was thinking a couple things. We're going to talk. This is our meeting. We're having it on the air.
Yeah.
So actually, I haven't told you this, but I actually got an email from a student down in West Palm Beach, Florida, who sent me a phenomenal review of all the different ongoing clinical trials right now and all the different medications and things that they're testing, all the different treatment options, whether it's combos or new drugs or whatever that they're testing. Sent me a link to that. And then I found out, you remember Patrick Key?
Petra.
Patrick.
Oh, Patrick. Yeah, Patrick.
He's at the VA doing his PGY2 in psych. Somehow he's the lead on the VA's task force for COVID-19.
Really?
And he sent me this thing. And he was like, "What the heck is happening? Why am I the lead on that?" And so he's got a bunch of the newest research too. So maybe we need to try to get both of them on here.
Nice. Did you see Plaquenil on that list of drugs? Yeah, I saw that. How interesting.
Yeah. There's a couple malaria drugs on there,
really?
And then along with some other stuff. It was interesting.
It's interesting. I'd like to see why.
Yeah. I'll show you the list. It's 7 pages long. I'm still waiting to hear back from her to see if it's cool if I share it and stuff. But it's
cool. Yeah,
something that's interesting.
We'll do a follow. Maybe after the dust settles a little bit, or do you just want to do it right in the midst of the fray,
just to show that?
Then we'll do one after the dust settles.
Yeah, I was like, oh, geez.
Yeah.
So,
because there's lots of dust up. That's
for sure. All right, but that's not what we're talking about today, even though it sounded just like we were about to talk about that.
It did.
We're actually going to cover a topic we meant to do a while ago, but kind of put it in the back burner. So we're coming back to it. Vertigo.
Mm-hmm. Vertigo and dizziness. Not what you want your patient complaining about.
It's one of those things that I think, especially, we're going to do our best to kind of go through some of the background and all that. But obviously, from a PharmD standpoint, the medication stuff's fairly straightforward as far as treating the symptoms. The workup and all the stuff that the specialists go through, super not our wheelhouse.
Right.
So I'm putting that disclaimer out there now
because
we're going to kind of give a little bit of background to the best of our abilities. But if you're an ENT specialist or neurologist and you're like, what are these morons talking about? It's just a couple of guys out here doing their best.
That's all we do. Yeah, med-wise, it's kind of, pretty much whatever you would think of for vertigo or dizziness is what is on the list. So it's mainly when's the most appropriate time to use them and when is an inappropriate time to use them, and then risk versus benefit for elderly patients. But we'll talk about that in a bit.
Yeah. So to get started, and I know Cole, you've done a lot of the background stuff, but I do want to kind of touch on something real quick that I'll do the best I can, audio and not without having a visual guide. Maybe we'll throw up in the video version, but talking about the vestibular system. So we were actually kind of discussing this before we started recording, because it's kind of crazy how this whole process work, and we're not going to go through everything, but just for those of you who had an anatomy class or physiology class but haven't actually looked back on it in a while, you guys have all seen the cartoon drawing of the inner ear canal and the cochlea and all that, but you see those three semicircular canals that were kind of on all those images. Unless you've actually kind of looked at that and kind of looked at some of the pathophysiology of vertigo, you may not have actually kind of looked through how those actually work. And that's something that, was pretty interesting to me, because I think that's just a fascinating kind of physiology behind it. But basically, to give you the very short gist, each kind of the semicircular canal is kind of at a right angle to the other two. So it's almost like the way that there's a Medscape article that kind of refers to as the three sides of a box meet at each corner. And so they kind of have, each one is in a certain plane that kind of is sensitive to certain rotations. And there's a rotation that lies in that particular plane of the canal. And so they kind of send signals through to the brain, and basically there's this fluid in there that is able to kind of, as it kind of fluctuates back and forth, the signals are sent to the brain, and it tells the brain which position the head is actually in. And even if it's an arbitrary kind of rotation, it can kind of figure out where it's at and keep everything feeling normal. Now when that system gets messed up, that's when you can start having some of these symptoms, or at least that's one pathophysiology part of it. But those three semicircular canals and that whole anatomy physiology component of it is kind of fascinating to me. So I'm going to post a video up from a group called, what was their name? Zero to Finals. I'm not really sure who runs that or anything, but they have a really good animated 9-minute video. I'll post a link to that, but it's pretty good.
Yeah, no, it's super fascinating, and the pathophys is very interesting, and like you were saying, plays a big part. The fluid is important because when things get in there that aren't supposed to be, causes symptoms. If you have pressure changes, so we'll frequently reference pressure changes, but where is that actually happening? If you have pressure changes in the inner ear, it can be caused by certain diseases, can cause issues as well. And then the vestibular nerve that's attaching to those, if it is disrupted or inflamed, another way that you can have symptoms. So we'll go through those. Yeah. But like I said, dizziness and vertigo are not the symptoms that you want to have your patient complain about, but it is among some of the most common symptoms that patients do complain about, as common as back pain or headaches. The big concern is, of course, twofold. Mainly, it's in the elderly and the risk for falls, so that's usually what you're concerned with. In the younger population, it's more of an annoyance and quality of life type of situation. So falling can be a direct consequence of dizziness, especially in the elderly. The risk is compounded if they have other neurologic deficits or other chronic medical problems. Their risk is going to go up. Overall, the incidence of dizziness, vertigo, and imbalance is 5 to 10% in the general population. And for patients over 40, it goes up to about 40%, which is very significant. The risk for falling in patients, there was a couple kind of epidemiologic studies I was looking at. So the incidence for falling in patients over 65 years old is about 25% if they have dizziness or vertigo. There was one report from 1995 to 2004 looking at U.S. emergency departments. And dizziness and vertigo accounted for about 2.5% of all patients that presented to the ED. In 2011, it was estimated that U.S. ED visits for dizziness or vertigo was about 3.9 million people. There's one Swedish study, kind of like a Beers criteria study for us, but it was the Swedish National Study on Aging and Care, found that patients under 80 years old had a prevalence of falling of about 16%, and that dizziness was 17% in those patients. For over 80 years old, the fall risk increased to 31%, dizziness increased to 31% as well. So definitely more significant as you get older, and we know what falling can mean for an elderly patient, especially if they have osteoporosis and have a break, and what that means for increased risk of mortality. So that's why we look into this.
So, Cole, I know you've obviously talked to your wife about this topic before. How much of this does she actually deal with, like on a daily basis? As she said, is this something that they come into a neurology clinic often about? Or are they going to ENT or?
I mean, usually this starts at the primary care level, right? You're going to go to your doctor and say, hey, I'm just feeling kind of dizzy. And he's like, oh gosh, it's like saying you're fatigued, right? All the workup that you can go do from there. So she works mostly with memory patients now, so she definitely does see it. And so dizziness and vertigo in patients with dementia is high risk because, a fall is higher risk. But usually it's going to start at the primary care level, and a lot of times it can be handled there. But there are situations, and we'll kind of go through those, where you would want to refer to a specialist. But for the most part, you want to try to handle it at the primary care level if you can. But you need to suss out the cause, what the cause may be. So the most common causes of peripheral vertigo. So there's peripheral vertigo. There's also central vertigo, and that kind of, determining the difference between those is important because it'll determine what you do to treat it. But peripheral vertigo, most common causes are BPPV, which is benign paroxysmal positional vertigo. So kind of thinking back to the vestibular system and the fluid, this can occur because you get basically crystallized formations that go into the fluid that aren't supposed to be there, and it causes symptoms. So hallmarks of that are it's caused by positional changes, because if you're sitting still, you're not activating that vestibular process, and so you're not going to feel symptoms. But with positional changes, it's not functioning correctly, and so you're going to have those symptoms that can last for about a minute. But that's hallmarks of BPPV. There's also Meniere's disease. The difference between that and BPPV, as far as symptom presentation, is that it's not going to be related to position changes. It can just happen. It can happen just with aging, and is usually associated with, I think it was hearing loss. It's kind of an inner ear disease. As
it goes on, hearing loss as well as tinnitus. The vertigo is part of it, but yeah, it can cause some longer term damage as stuff goes on. It's that excessive endolymph buildup causes that pressure, and so it's more of a damaging long-term thing.
Increased pressure with that fluid. The last one is vestibular neuronitis, which is inflammation or disruption of the vestibular nerve, and you can also get symptoms from that. So those are all examples of peripheral vertigo.
And going back to the first one that Cole was talking about, the benign paroxysmal positional vertigo. That's one that a lot of, depending on which reference you're looking at, says is typically the most common cause of vertigo. And the crystals that he was talking about, the basically calcium carbonate crystals, they call them otoconia. And, that whole system of the fluid, the endolymph being kind of like positioned and kind of signaling through those semicircular canals, those crystals, because of they're in the lymph, they travel and they throw off the system. So it basically tricks your brain into thinking your head's in a different plane, if you will, than it actually is. And so those crystals kind of like flopping around in the water, basically, and sending those signals is what triggers it. It's kind of fascinating that something such a tiny little thing can throw off your entire system. I don't know. I'm just fascinated by that.
No, what's fascinating is that the system works so specifically, and it's so small, and it seems like it'd be way easier for that to whack up. But
something you take for granted,
right? And I mean, we can get dizziness from spinning around with a bat on our forehead, but
something we do frequently.
Right, we do it before every podcast. Keeps us going in the right direction.
Could you imagine if we had a guest on and we started doing that? And they were just like, what are you doing? This is our ritual. We have to spin around 6 times before we start. Clears our head.
Yeah.
The end of guests. But you said something interesting kind of when you're talking about going to the primary care doctor and saying patients will come in and say, I'm dizzy. So one of the things that is kind of recommended when you're doing the workup initially and kind of getting a history of the symptoms and all that is to ask the patient to describe the symptoms without using the word dizzy. Because I think that's a very common, I would say that myself, I think if I was describing to somebody. So that's a good kind of like first step, and then kind of see where it goes from there. Asking them if it's a feeling of actually being like pushed down or pushed to one side, like they can refer to that as pulsion, pushed to one side or the other. Asking them if it's something to do with, some sort of an anxiety episode, because that can actually present itself to the patient as dizziness, but it's actually stemming from the anxiety.
Right.
Is it something that happens continuously or episodic, like Cole was talking about with Meniere's versus, others? It's one of those things, is it coming and going? Is it lasting a long time? And, getting a very thorough history, and obviously on the pharmacology side of things, that's not really what we're doing, but for the interprofessional collaboration, your provider's side is going to be getting all this information, and then it's also going to help you kind of make a better pharmacotherapy recommendation if needed,
right?
In that aspect too.
Yeah, dizziness is just very non-specific. So, like you mentioned some examples, some other examples people might use dizziness to describe was obviously vertigo, but also unsteadiness, generalized weakness, syncope or pre-syncope, even falling. They might have had a fall, and they might just say, well, I was dizzy, and you might not even realize. But yeah, history is very important. It should include a complete neuro-otologic physical exam, including vestibular examination. So for those of you medical professionals who know how to do that, right on, because pharmacists don't do that. But yeah, it should focus on the nature of the symptoms, duration, what triggers it, what helps it. And yeah, just try to avoid the use of the word dizzy. Dizziness might be lightheadedness, motion intolerance, feeling of floating, a tilting sensation, where vertigo is more of a subtype of dizziness, and it's kind of an illusion of movement caused by asymmetric input to the vestibular system, like we said, and that different from other types of dizziness.
And also, looking at the medication list is something also too that it would be on the pharmacist end. It would be looking at if there's any medications that could either cause some form of ototoxicity, things like aminoglycoside exposure, things like anti-neoplastic drugs, anything like that, like cisplatin, anything that can potentially cause that, or even something as simple as antihypertensives, like where they just started, on doxazosine for hypertension because their provider doesn't want to do the right medications for hypertension, something like that. I mean, it can be something as simple as, that, or, just making sure you're doing a medication reconciliation to figure out what is going on.
Yep. And along with the physical exam, you want to look at supine versus standing blood pressure measurements, something that can affect, if they have orthostasis and they're trying to stand, they can definitely get dizzy. Also looking at the vestibular reflexes, like the vestibulo-ocular reflex, the VSR, the vestibulo-spinal reflex.
Gait
testing, yeah. Examining the ear, just looking at it for visual infection or inflammation, hearing indiscrimination, using the tuning fork, all those good things that they do when they're doing a physical exam.
Didn't you say that your wife was talking to you about I think it was the Hall Pike maneuver? Yeah,
doing maneuvers to test and then also maneuvers to potentially fix or relieve. Yeah. I think what do they call that? Vestibular rehabilitation.
Yeah.
Different than normal physical therapy, but something the maneuvers you can perform in office, primary care docs can perform in office that often can resolve the issue.
One of the ones I saw when we were kind of looking at some of this, and again, I don't know how often this is actually done. I just love the name of it, called the head shake test.
Yep.
The examiner vigorously shakes the patient's head in a horizontal plane from side to side, 10 to 15 seconds.
You dizzy now? You dizzy now? Huh?
How about now? I'm sure that's useful, but it just seems like a weird thing. I just love how they what do we can call this thing?
Now I want you to take this bat and I want you to put it on your forehead.
I feel like if my doctor was doing that, I'd be like, oh no, I went to a quack job. But
head shake test.
The head shake test. It's classic.
Oh man. That's what I do when, people ask me if I can fill their prescriptions, 3 months early because of the
head shake test?
Yeah.
Absolutely not.
Because of the coronavirus. Head shake test.
Yeah. But 3 months early, we're not even there yet. What are you talking about?
Spend my whole life dizzy in the pharmacy.
Yeah. I cannot do that. So you want to go into some of the medications that can treat some of at least the symptoms of?
Sure. Yeah.
You ready for that? You got something else before, Sam?
No, we can do that. I'll come back to a couple things, but yeah, let's go ahead. What we got? I guess the first thing I always think of is Antivert, right?
Yeah. Meclizine. So Meclizine, and as well as that, they also have even the first generation, if you will, like the antihistamine. So diphenhydramine can be used, so Benadryl, but also the one that we kind of probably always think about the Dramamine, the original Dramamine, which was dimenhydrinate. Dimenhydrinate is one of those that's, and same with diphenhydramine. It can help in some cases. It's been around for a long time, and it can help with the dizziness. But however, all the different adverse effects that come about with it, that we always think about with those. One thing that was kind of interesting with like dimenhydrinate, the Dramamine, is that it's actually like a combination. So it's actually a salt form, and it's almost a 1-to-1 ratio of diphenhydramine of Benadryl, and then this other thing called chlorotheophylline, and so it was supposed originally I found an article from like 1951 that was talking about the research they were doing with it.
They had articles back then,
I guess, and this might be
carved into stone,
scanned in. I don't know, but what they were showing was that basically the blockade you get from the histamine on the histamine receptor from the diphenhydramine, they were trying to offset the drowsiness and whatnot by giving this other chlorotheophylline aspect, which has more anticholinergic effects. They were trying to get a stimulant effect out of it, but that's where there's been case reports of showing paradoxical agitation with that drug, and so they've that's actually where that's stemming from, is that other drug that's in combined with it to form the actual Dramamine.
Interesting. So the people who are like, Benadryl doesn't make me tired, it makes me jump off the walls.
They're just getting a higher dose, their body's reacting more on that CNS stimulation.
Interesting.
The other thing is, I actually didn't realize that was a drug that some people abuse.
Benadryl?
No, Dramamine.
Dramamine?
They apparently kids will, I'm assuming mostly kids, but kids will take this and use it as a deliriant, and kind of like other things like robo-tripping and things like that. They'll get over-the-counter meds. I was looked up some of the nicknames. They call it things like Substance D or D-House or DQ.
D-House.
DQ. Then I realized how, I don't know, just not with it I am. Because if I was in high school and somebody was like, "Yo, you want to do some DQ?"
I'd be like, "Let's get some ice cream."
I actually love ice cream. Let's do this right now. Yeah, I don't think I was one of the cool kids.
You weren't down with the D-House?
I was not doing D-House that I knew. I didn't even know it was a thing.
The only thing I will say about Benadryl is you can't be dizzy while you're sleeping. So
true. Yeah.
But that is that's how it works. It has its central anticholinergic activity, so it's diminishing that vestibular stimulation, depressing the labyrinthine function, and less dizziness, less vertigo. Can't be dizzy while you're asleep.
There you go.
But of course, Benadryl is going to be on your beers list, and most all of these that we're about to talk about are going to be on your beers list. So if you have patients complaining of, let's say, memory disorders, take a look at their meds and see if they've been put on one of these because they were dizzy at one point, and that can contribute to that. Mm-hmm. And just the CNS depressant portion of it can put them at more of a risk for falling than maybe even the vertigo does. So risk benefit with these things. But meclizine would be probably next. Both of these you can get over the counter. Meclizine decreases the excitability of the inner ear. Labyrinth as well blocks conduction of inner ear vestibular cerebral pathways. So basically just diminishing that vestibular response too. Similar thing. But it was branded under Antivert.
Antivert, yeah. I also have scopolamine. Is an anticholinergic that is sometimes used. You see this a lot of times as the patch, and they'll use that in cruises and
which
such,
nobody's going on now.
Yeah, definitely.
Could have gone on a $150 cruise to like Alaska or something.
You probably get some really cheap cruises right now. I would imagine. I haven't looked, but they use it in motion sickness. There's as far as things like vestibular neuritis and things like that, because it's got such a slow onset of action, it's probably not going to be good in a lot of those types of things. But in theory, there are patients that will get put on this to try to help with some of the symptoms, but probably not one of the better options.
Yeah, kind of a slow onset.
Yeah, and you're not going to get nearly as much of the. I shouldn't say nearly as much. You're not going to get, in theory, as much of the sedation and some of that stuff as you would like a straight up Benadryl.
Right.
But very slow onset.
Slow onset. It antagonizes the actions of histamine and serotonin. But basically, they would recommend something like glycopyrrolate over scopolamine. So glycopyrrolate blocks the action of acetylcholine at the parasympathetic sites. It's branded under Robinol, but that is another option. It works centrally and can help with vertigo.
Yep. Benzos.
Yeah, you ever gonna give this for dizziness and vertigo, man? Golly.
Yeah, I would have a hard time justifying that when I'm by no means a specialist in this area, but I guess in a way, if it's stemming from like true anxiety, maybe.
If it's anxiety or if
like
it's
that.
if it's like, I don't know, some other more significant disease than something that's, benign, I suppose.
Or if you've tried other things, and especially if the person's tried multiple agents and they're also, vomiting or something like that with the vertigo, maybe it'd be an option then just for a short term to see if it helps.
I have seen patients who they have vertigo, they have anxiety, and like it results in like cyclic vomiting syndrome, and so they're like they have like diastat because they have cyclic vomiting syndrome from their vertigo and dizziness. I have actually seen severe cases of it where that would be warranted.
So not out of the question, but I would definitely say hold off on that until you know for sure you need to use that, especially not like a long-term thing in most cases.
Yep. Also, phenothiazine derivatives like Phenergan and prochlorperazine are options. So Phenergan, promethazine, it's an antidopaminergic. Probably more for the nausea associated with the vertigo than the actual vertigo. But glycopyrrolate is probably safer than that and has less adverse effects.
Yeah. Prochlorperazine is one of those weird drugs that we don't hardly ever see anymore unless it's being used for something like vomiting from a migraine or something like that. Same kind of thing. It's depressing the reticular activity system, blocking that postsynaptic mesolimbic dopamine receptor. Another isn't that the drug they also use for like hiccups? Is that the one? Off-label use?
It might be. I know there is one. I'm not sure what it is though.
I feel like that's it. I might not be right. I'm not going to look it up right now.
Okay.
But that's again, I think with all the side effects and things like that, you still got to be kind of cautious with those too.
Yeah, all of these are going to be pretty sedating. If you're elderly and you have vertigo and dizziness, more of a tough situation for sure. Yeah.
What else you got? What other treatment options?
I saw something about ephedrine.
Yeah, I saw that too.
Stimulating release of epinephrine stores,
alpha and beta receptors.
Yeah. I don't know
about that one.
Yeah.
I think you'd have to be real careful with that one as far as blood pressure and things like that.
Right.
I'd have to see some stuff. I didn't look in depth into that one as far as like studies or anything.
Right.
But I guess maybe I've seen low doses of Elavil used as well. But I feel like the antihistamines, anticholinergics are the ones that are going to be the most commonly used, at least, at first and for, until they can figure out exactly what's going on.
Right. And it, depends on the cause. So going back to vestibular neuronitis a little bit, it's the most common cause of acute vertigo. Incidence of about 170 cases per 100,000 people. Sometimes it can even be reactivated by herpes simplex virus if you have HSV. But a brief course of antiemetics, vestibular suppressants can usually kind of handle it, but also corticosteroids. So they will prescribe steroids in that case for the neuronitis.
And I think I think some cases they'll even use like fludrocortisone with its mineralocorticoid activity as well. Yeah. In particular, with that, if that's what they're actually treating with it. And I've even seen in that particular case when they know that it's stemming from a viral infection, they'll suppress it with acyclovir and things like that in the short term. And so that's something I like. Treating the underlying condition, I think, is always going to be the main focus. Another drug that they'll use sometimes that we didn't talk about is also metoclopramide, Reglan.
Yeah.
This is one of those that, it's decreasing like gastric motility, and you'll see this sometimes used in like gastroparesis and things like that. But that's one of those drugs that it actually can cause like EPS.
Yeah, I was going to say, yeah.
I definitely would not recommend that long term at all. So make sure that if it's you're going to use something like that, it's short term if possible.
Right.
But yeah, that's one of those drugs that I think has been around for a long time, but not probably a great option.
EPS is not fantastic.
And they may even use something like Zofran as well.
Yeah.
Not a lot of...
For like the antiemetic portion.
Yeah. That's something you'll see pop up in those lists of vertigo treatments to treat to block some of that serotonin as well as treat the nausea and stuff.
I found more about the maneuvers. So it isn't BPPV, whereas the maneuvers are most effective. They call them canalith repositioning from the affected canal back to the vestibule where it is absorbed using the most common maneuvers. So the maneuvers options are Epley, Seamont, Lempert, and Hamid. Hamid for horizontal canal, capulolithiasis, and I believe the Epley maneuver. That's the one I'm more familiar with. But the Epley maneuver can be done in office, and once the history and examination confirm the diagnosis of BPPV, definitely something you can try. And, keep them off medication, get it done right then and there, bada bang, bada boom,
As they say.
Yeah, as I say.
So yeah, that's just a couple quick reviews of treatment options and all that fun stuff.
Yeah, that is, vertigo and dizziness.
And there you go. There you have it.
You got everything you need.
I would encourage you to do a lot more research.
Yeah.
And especially if the going through the diagnostic tests and stuff like that interests you, there's a lot of good resources out there. Medscape has a lot of good articles.
It's definitely the hardest part, which we're not experts in, is just figuring out the underlying cause. But at least now you're aware of some of the underlying causes.
Oh, man. Yeah. There you go.
We do what we can.
Yeah, it is what it is. But anything else on this you want to talk about?
That's all I got, man.
Cool. We figured this would be a short episode, but we'll try to. We had a slow start to the month, so we're hoping to get a couple more
Crank
out
out a few more, yeah.
pretty quick and get caught back up. But if you guys have any specific topics or anything you want to hear, let us know. We'll put it on the short list that we have already started, and hopefully get it out in the next month or two. And also, one of the things we always bring up, like reaching out to us on social media or whatever, Instagram. One of the things we're going to ask you to do is a favor to us. If you use YouTube at all, we're really trying to grow our subscriber list on YouTube. YouTube will give you special tools and stuff that you can use once you reach a certain level of subscribers. So if you enjoy this podcast at all, we promise not to bombard you with nonsense on YouTube, but if you could subscribe to us on YouTube, that would help us out a ton. We would greatly appreciate it.
Believe it or not, we do videotape most all the episodes. We sit here with a camera in front of us.
Yeah, it's weird.
For those of you who had no idea.
So, so if you could subscribe to us, we would greatly appreciate it. It would help us out. And hopefully this year the plan is to actually go really hardcore into the video versions of it. So we're going to get
unless you think
cameras.
that just seeing what we look like would
totally ruin it,
would ruin everything.
Yeah, you're not going to like it.
Yeah,
you're
might not be for you.
But still subscribe though. Just don't watch the videos.
Just don't look at us. Just just watch, hit play. But then put a little black piece of paper right in front of the video.
Wow.
And just listen to it.
Yeah.
And subscribe.
I feel like Cole has a very self-loathing attitude towards the way we look, but it's fine. That would help us out a lot. And we got some cool stuff coming out with video. Like I was saying, we're going to hopefully have multiple camera angles and some showing references on the screen and stuff like that. We just have to get some very expensive equipment first. So we're putting that hopefully on the list this year that we're going to get knocked out. So thank you guys so much for listening. And if you do need anything, reach out to us on email or any of the social media platforms. And we will catch you next time. Later.